Good morning, all of you. So let's just start the class. So today I'm going to revise this topic from the very beginning because this is a very important concept in obstetrics. Okay, don't worry about the uh, courses, we can handle that. So labor, okay, means it's a series of events which takes place in the genital organ in an effort to expel the viable products of conception out of the uterus through the vagina. Labor is not a single process or phenomena. It is a series of events. Delivery is a part of labor. Remember this. So labor has got different stages. First stage of labor, second stage of labor, third and fourth stages of labor. So different stages are there. So what happens exactly in labor? It has a series of events which takes place in the genital organ of the mother, and the purpose or objective of that labor is to expel the baby outside. That is labor. Delivery is a process of expulsion of viable fetus out of the womb. Now that second stage of labor actually is called delivery. We'll talk about that in detail in the coming classes. Now this is a very good and short and sweet definition of labor. You can clearly see here. It is defined as the onset of regular painful contraction with progressive cervical effacement and dilation accompanied by descent of the presenting part. So see there, first stage of the labor and second stage of the labor are defined here actually. So first stage of the labor is characterized by onset of uterine contraction. This is called labor pain, which gradually leads to effacement of the cervix and dilation of the cervix. In the last class, okay, I talked about what is effacement of the cervix. Anybody still remember what is the meaning of effacement? Yes? Anyone?
Softness and thinning of
It
the
is that,
cervix.
it is that cervical dilation and thinning of the cervix, sir.
Good, good. Many of the students are answering it correctly. This is thinning, okay, and stretching of the cervix. Thinning and stretching. Remember, to if a cervix, okay, will get thinner, there has to be stretching. So stretching and thinning, if you just say thinning, it will be fine, no problem. So this is called effacement. And the maximum diameter of the fetal head is 10 centimeter. That is called biparietal diameter, BPD. So to pass that 10 centimeter, cervix has to be dilated by 10 centimeter. That is called full dilation of the cervix. We'll talk about all of these things in the subsequent classes, okay? But if I say or tell you right now, it will be so easy for you to understand. So this is the labor. Now, labor or normal labor has so many important criteria. So these are the different criteria for the normal labor. So let us revise once again. It should be spontaneous in onset. The labor pain should start on their own without use of any medicine. This is such an important point. And it should start at term, that is 37 completed weeks till 42 weeks of the gestation. And it should lead to delivery of a single baby. If there are twins, if there are triplet or quadruplet, more than one baby, it is not a criteria of normal labor. Second point, the baby has to have vertex presentation or cephalic presentation. This is important. No buttock presentation or breech presentation, no shoulder presentation, nothing else. Only vertex presentation is considered normal labor. The baby should be delivered by vaginal route. Somehow, if cesarean section is done, it is not considered normal labor. Cesarean section is a type of surgery. It should occur within time. It should not be excessively prolonged, and that time, okay, is 18 hours. It should not cross 18-hour duration. Now see here, There is one a very important statement which you may come across different obstetrics book. A pregnant lady should not see two sunrises or two sunset. Okay, two sunrises or two sunset. So we all know, okay, the time gap between two sunrises is 24 hours. So 24 hours is already a bit longer, remember that, but we can adjust around that 6 hour time. She should not, the labor should not extend at all than 24 hours. Preferably it should not be exceeded more than 18 hours. The labor or delivery should be naturally terminated with minimal aid. Okay, it should be naturally terminated, and then there should not be any complication to the mother or the baby. Both of them should be healthy after normal labor. So these are the very important points you should never forget. Normal labor is also known as eutosia. This is the medical term. Now, what about dystocia or abnormal labor? Any deviation from the definition of normal labor is called abnormal labor. Quite easy. So, if a baby is delivered by cesarean section, it is not normal labor at all. Okay, this is abnormal one. There are multiple pregnancy, abnormal labor. So all those things are there. Now let's move further. The natural labor can be thought of as having three components, and we have made this discussion easy by giving different terms and names for that. That is power, passages, and passenger. Now, power is mainly involving uterine contraction. Uterus is made up of smooth muscle. The myometrium of the uterus has a smooth muscle, and that can contract vigorously. That acts as the most important source for power. At the same time, okay, the lady can also develop contraction of the anterior abdominal wall muscle as well as diaphragm, which will help to push the baby downward. So they are also very important source of power in the second stage of the labor. Regarding the passages, okay, there is bony passage and soft tissue passage. Like pelvic bone, pelvic cavity acts like a bony passage, and soft tissue passages are lower part of the uterus, vagina, vulva, and the supporting tissues there. Different ligaments are involved. So they acts like a passages. And passenger, the most important one is the baby or the fetus. Placenta as well as membrane, they also needs to come out. They cannot stay there after the delivery of the baby. Now what happens if placenta and membranes are not delivered? What will happen to that pregnant, I mean the lady who has just delivered? Yes?
Continuous hemorrhage.
Hemorrhage, sir.
Hemorrhage, sir.
Severe
Hemorrhage.
Very
bleeding.
good. Very good. Excellent. Hemorrhage. Hemorrhage. That's the most important answer. Okay. So the lady keep on bleeding for a long time, and she may even develop hemorrhagic shock if it is excessive. So placenta and membrane must come out after the delivery of the baby. Now we are reaching, please mute yourself. We are reaching to the important part already discussed in the last class though. What are the causes of onset of the labor? See here. Okay. Now see there. There is, you have to remember this axis, the fetal pituitary and fetal hypothalamus. When the time for labor pain start, that means when the baby reaches term, there will be release of ACTH from the fetal pituitary, adrenocorticotropic hormone. This ACTH acts on the fetal adrenal gland and it releases glucocorticoids. This glucocorticoid will lead to synthesis of these three important substances. Actually, I should say two important substances and one is reduced with the effect of glucocorticoid. The most important one is prostaglandin, another is estrogen, which are increased or more synthesized, whereas progesterone is decreased. Now, what is the combined effect of these three things? Okay, That's what you need to understand here. Because of increased estrogen, it will cause increased release of oxytocin from maternal pituitary nerve. And oxytocin is a very powerful hormone which causes contractility of the uterus. It causes contraction of the uterus. Very important point. Another one, okay, because of this excessive estrogen, it promotes the synthesis of oxytocin receptor on myometrium, so that this oxytocin can act very easily on the receptor and more effective contractility of the myometrium can occur. So this is the role of estrogen. At the same time, progesterone, remember, okay, progesterone is a relaxing hormone. So if there is excessive progesterone, then uterine contraction cannot occur. So the level of progesterone should go down. Then only uterus can contract. So exactly that things happen. And then there is increased synthesis of prostaglandin. Prostaglandin has two very important functions. One, it causes uterus contraction, and second, it causes softening and dilation of the cervix. Softening and dilation of the cervix, which is very essential for the descent of the baby and delivery of the baby. Now the same thing which we talked, let's repeat once again. See there, because this is a very important concept. All the students should know about this. See, there's fetus. ACTH is coming from the anterior pituitary gland. It acts on the adrenal gland, and then increased glucocorticoids will be secreted. A bit of androgen is also increasingly formed. Now, there is an effect on progesterone, which is decrease in the placenta, and increased estrogen secretion. This estrogen will cause increased release of prostaglandins, which causes increased uterine contraction, softening of the cervix, and increased uterine sensitivity to oxytocin. This is also done by prostaglandin. But these two you should never forget: increased contractility and softening of the cervix. Now, see there, this progesterone, when it is decreased, the opposite thing will be stimulated, that is uterine contractility, and oxytocin would be released. This oxytocin would be released by excessive level of estrogen, and one more phenomena is also there. Because of the stretching of the cervix and vagina, okay, some neural pathway will be stimulated, and that neural pathway will further lead to oxytocin release. Oxytocin is a very powerful contractile hormone for the uterus, which can lead to start of the labor. So this is how normal labor start. Now we are moving into the very important part of this class: how diagnosis of labor is done. How I know the lady is in labor? So there are different points. So we have categorized them under different headings first. The first one is diagnosis and confirmation of the labor. The second, what are the stages and phases of the labor? The third one, is the presenting part engaged in the pelvic cavity or not? And what about the descent of the presenting part, that means fetus? And lastly, okay, we have to identify the presenting part and what is the position of that presenting part in relation to the maternal pelvis and birth canal. So these are the different headings under which we can discuss this topic. Let's start with diagnosis and confirmation of the labor. Okay, so please pay attention here. The first thing is, in which case you suspect or anticipate labor. Okay, anticipate means you believe the labor is going to start very soon, or there is a delivery of the baby which occur very soon. That is anticipation. And suspicion means some symptoms and signs has to be there, and those are, if there is intermittent abdominal pain occurring after 22 weeks of the gestation. Okay, so this is a very strong signal that this lady is going to deliver, and this is called labor pain. Along with labor pain, if there is blood stained mucus discharge, which is called show. Okay, show. This is a medical term you need to remember. Blood stained mucus discharge from the vagina along with this labor pain is called show. It also signifies labor is very nearby or already started. And then if there is watery vaginal discharge or a sudden gush of water from the vagina, and every student know, I asked this question in the last class also, and they say this is because of amniotic, okay, membrane rupture. There is sudden gushing of the amniotic fluid outside. So all of these are, symptoms or signs of labor. Now, okay, so let's move further. Let's move further. See here. What is the difference between true labor pain and false labor pain? So, true labor pain occurs because of uterine contraction at a regular interval. These are real contraction of the uterus, and these are quite painful. And one of the very important point is the lady complains the second or third contraction is more severe than the first, means the intensity and the duration of the contraction, okay, is increasing after each of the contraction. This is the hallmark of true labor pain. Along with that, there is show. This is mucus discharge along with bleeding. Show, very important point. Another one, along with true labor pain, there is gradual effacement and dilatation of the cervix. Cervix will be stretched and get thinner. At the same time, it will be dilated. Always remember that without effacement and dilatation of the cervix, delivery is impossible. So it will happen along with true labor pain. And there is formation of the bag of water, which we can detect per vaginal examination. When we put finger and examine, there is a formation of the bag of the water. This is because of the contraction of the uterus, which is constantly pushing the amniotic fluid or amniotic, membrane or bag downwards. Now, what do you mean by false labor pain? No, not all, painful or abdominal pain at or around the labor time is true labor pain. Sometimes they can simply be false labor pain. So every student should know how to differentiate them. And this is a very common question which is asked in the exam. Now see here, the false labor pain is a dull in nature and confined to lower abdomen. Whereas true labor pain, it may start from the backside and come on the front. But false labor pain is not like that. It is confined to the lower abdomen only, and it is dull, aching in nature, a bit of continuous type. It is not rhythmic or it is not intermittent type of pain. Continuous, dull, aching pain is a false labor pain. Another important point, when you put your hand on the anterior abdominal wall of that lady, you will not feel any hardening of the uterus because it is not associated with contraction of the uterus. This is false labor pain. Third one, it doesn't have any effect on the effacement and dilation of the cervix, and that is confirmed by per vaginal examination. You don't feel the cervix is dilating anymore. This is false labor pain. Now, it is not because of uterine contraction, right? So it has to be, okay, because of some other causes, and those are stretching of the cervix and lower uterine segment with consequent irritation of neighboring ganglia. So this is because of irritation, okay, irritation and stretching. It is not because of uterine contraction, and sometimes it can be there because of urinary tract infection, which is quite common in pregnant lady, or any local infection in that area. So remember, there is false labor pain uh, in that time, I should say. So one of the statement which can say is all abdominal pain at or around the time of labor are not true labor pain. They can be false labor pain. And as a medical student, as a doctor, it's our job to distinguish whether this is a true labor pain or false labor pain. If it is true labor pain, we must admit the lady to the hospital for the delivery because it is very eminent. But if it is a false labor pain, we can discharge her, okay, and call her later on by describing what are the features of true labor pain. Now, let's move on. How to confirm the onset of labor? So see there, we can confirm the onset of labor if there is cervical effacement and cervical dilatation, which can only occur after true labor pain. Now, every student know by this time the meaning of cervical effacement. See here. So let me explain this. The progressive shortening and thinning of the cervix during labor is called effacement. It is shortening and thinning. Stretching and thinning are a similar type of terms, and gradually the cervical canal which was there getting shorter and shorter, and ultimately that canal would disappear. This is called cervical effacement. Along with this effacement, there is dilatation of the cervix. See there, okay, I already told you the maximum cervical dilatation is 10 centimeter. It is 10 centimeter. Let me write that for you, 10 centimeter, because okay, the maximum diameter of the fetal head, which is called BPD, okay, BPD, BPD. Now, what is the full form of BPD?
Bipyramidal diameter.
Bipyramidal diameter.
Diameter, sir.
Excellent. Biparietal diameter. Okay, never forget this. Biparietal diameter. This is the maximum diameter of the fetal skull. It is 10 centimeter. So this has to pass for the baby to come out. So that cervix should also attend, okay, same type of dilation, that is 10 centimeter. Let's move on. Okay. Now, see that let's explain this effacement and dilatation with the help of some diagrams. So this is the upper uterine segment, and here is the lower uterine segment. Now every student know this already because I've explained this so many times. Upper uterine segment is a muscular part. During the labor or even during the third trimester, okay, of pregnancy, this difference between upper segment and lower segment is already defined there. Lower segment is the thinner segment, and during the process of labor it gets, okay, dilated, means it has to give way for that baby to come down. And upper segment is a highly contractile part of the uterus. Now see there, the upper segment progressively gets thicker and the lower segment gets thinner when labor start. Now all of you please pay attention at this slide, okay, please pay attention on your screen. It's very important knowledge here. So let me explain this. In this picture you can nicely see the cervical canal here. Look at this canal. This is a cervical canal. Okay, I can still identify the cervical canal in this picture. So cervix is not effaced at all here, and the length of the cervical canal is around 4 centimeter in this picture. Now when I go to B, now see this, the cervix is partly effaced and the length of the cervical canal is reduced to 2 centimeter now. Okay, when I go to C, the cervix is fully effaced now. It is thin. It is much thinner than in this. And where is the cervical canal now? It disappeared. In D, cervix is dilated. After it is effaced, it starts to dilate now. So it has dilated up to 3 centimeter. And in E, the cervix is dilated up to 8 centimeter. Remember, the maximum dilatation is 10 centimeter, okay? So still 2 centimeter has to be dilated. So this is called effacement and dilatation of the cervix. Now, please pay attention on this picture once again. This is also very informative one. See that when cervix is not fully effaced in the beginning, what it is, the process is just started. See here, it looks like a T, letter T. It looks like a letter T. So this is a cervical canal. This is internal os. This is external os. Now gradually, okay, it will become Y. It will become V, and ultimately it will look like the letter U. See this. Where is the cervical canal here? Okay, it is not. I mean, it is already completely effaced. So this is called effacement of the cervix. This is the understanding. Okay, and this is what we are talking right now. Now, after understanding these things, let's go to the another part: how to diagnose stage and phase of the labor. What do you mean by first stage of the labor? What is second stage? What is third stage? And what is the fourth stage? Now, please pay attention. First stage of the labor starts with onset of true labor pain up to full cervical dilation, that is 10 centimeter. It starts with onset of true labor pain. And what are the hallmarks of true labor pain? Let you remind you once again. This is a painful uterine contraction. Along with those uterine, I mean the abdominal pain, when we put our hand on the anterior abdominal wall, we can feel the hardening of the uterus. Very, very important point. So then only we can confirm, yes, this pain is because of uterine contraction. First point. Second, the second, third, or fourth or subsequent uterine contraction will be more powerful and painful than the first one. This is the hallmark of labor pain. And usually it starts from the lower back side and gradually comes on the frontal side. It will be associated with show. Okay, show, 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 that is mucoid discharge. A bit of blood is also there. So these are very, very important point. Now what I'm talking here, the first stage of the labor, it starts with onset of true labor pain up to 10 centimeter dilation of the cervix. So you can easily say from the onset of the labor till full cervical dilation. Never forget this. Now how long it lasts? Its duration is usually 12 hours in primigravida and 6 hours in multigravida. The primigravida, they are pregnant for the first time. So first stage of the labor is also quite prolonged in them, almost 12 hours, and just 6 hours in multigravida. Now, first stage is divided into two phases, latent and active. We'll talk about this phase a bit later. Let me do with the staging first, okay? Then we'll move on to the phases. Now, what is second stage of the labor? From the full dilation of the cervix till the expulsion of the fetus, that is called second stage of the labor. So when you do per vaginal examination, you will confirm the cervix is fully dilated, that is 10 centimeter, till the baby fully come out. This is called second stage of the labor. In an average, it lasts around 2 hours for primigravida and 30 minutes for multigravida. This is an average, okay? All ladies will not follow this. There is always a range, but this is the average value we are talking about. 2 hours for primigravida for second stage of the labor, 30 minutes for the multigravida. Second stage is divided into two phases again, and these are non-expulsive phase and expulsive phase. In expulsive phase, the baby would be pushed outside. Now, after doing first and second stage of the labor, what do you mean by third stage and fourth stage? Pay attention here. Third stage of the labor is the time, here, is the time from the birth of the baby, to the expulsion of the placenta and the membrane. So you can easily say delivery of the placenta and membrane is third stage of the labor, or at this stage there is expulsion of the placenta along with the membrane. In an average, it is 15 minutes for both multigravida and primigravida. So there's no difference. It is same length for both of them. Duration is significantly reduced by active management of third stage of the labor. Now, active management of the third stage of the labor, we'll talk about this during the management of labor class. Okay, very important class. We'll do that in the coming subsequent classes. So what do you mean by that? After the baby is delivered, we don't wait for 15 minutes for the expulsion of placenta and membrane. The nurses or the midwife or even the doctor, whoever are there, they can simply give traction to the umbilical cord, and they can slightly pull the umbilical cord so that the placenta can be easily separated from the uterine cavity and delivered earlier. This is called active management of third stage of the labor. And at that time, many of the ladies are getting oxytocin. Okay, they are getting oxytocin, and that oxytocin will cause contraction of the uterus. That will also help in the separation of the placenta, and then it will come out easily or much earlier than 15 minutes. Now, the last stage is the fourth stage, and it is not a real stage actually, but it is mentioned in many different textbooks. It is a stage of observation for at least 1 hour after the expulsion of placenta. Now, why this observation for at least 1 hour is important here? Why? Anybody?
So for checking any
chance
part
of
of placenta
bleeding.
remain any part of
That will
placenta
be
remain in
for
uterus
sir, complication.
for any bleeding.
Good.
Just for bleeding or anything remain inside uterus.
Like when a postpartum bleeding, sir, any sort of complications, sir. Looking forward to
Good. So all of you are answering absolutely correctly. Okay, all of you. Wonderful. This observation is mainly done to observe for the bleeding, any bleeding which is occurring there or not, any excessive bleeding, what I mean. Because sometimes some pieces of the placenta or some of the membrane may stuck inside and we are not sure. Okay, so if something is still there, there will be bleeding, there will be severe bleeding. And one important term is there which is called postpartum hemorrhage, PPH. PPH is quite common in so many ladies there. So the observation has to be done for at least 1 hour. Okay, that is called fourth stage of the labor. Now, okay, what are those phases of the labor? Now, the first stage of the labor has got two phases, latent phase and the active phase. Now, this is also very important knowledge. First stage of the labor takes a long time. Okay, remember that. It takes a long time. Now, that longer duration is again has two different phases. Latent phase, when the cervix is dilated less than 4 centimeter, and this phase takes a much longer time of the total duration of the first stage. That is, it is about 4 hours in multigravida and 8 hours in primigravida. See there? Okay, 8 hours in primigravida. If 12 hours time is there for primigravida, almost 8-hour time is taken by the latent phase, and only remaining hour is taken by the active phase. Now let me explain this in another way. You have admitted the lady because of true labor pain, but there is no cervical dilation till now. Okay, so it takes a long time for that cervix to reach up to 4 centimeters. So this total duration is called latent phase. What about the active phase then? In active phase, the cervix would be more dilated, means after 4 centimeter till the full dilation, this is called active phase. And in this phase, the rate of dilation is typically 1 centimeter per hour in primi, or more than that, around 1.5 centimeter per hour in multigravida. So after it reaches 4 centimeter, it will fasterly, it will progress very fast. That's what I mean. It will rapidly progress and reach to the full dilatation. And during active phase, okay, of the first stage of the labor, the fetal descent also begin because of the vigorous uterine contraction. Okay, because of the contractility of the anterior-abdominal wall muscle, the fetus slowly descending downward. The second stages of the labor, again, there are two phases. Non-expulsive phase, which is known as early phase of second stage, and expulsive phase or late phase of the second stage of labor. Now, in non-expulsive phase, the cervix is fully dilated now, that is 10 centimeter. Fetal descent already started, remember, it will continue, and there is no urge to push. The lady okay, doesn't push during this non-expulsive phase of the second stage of labor. Whereas in expulsive phase, the presenting part of the fetus is reaching the pelvic floor, or it is touching the pelvic floor, and after that the woman has the urge to push. Okay, she has urge to push, she is pushing actively during expulsive phase. So these are the two phases of second stage of the labor. Now let's move on. All of you, please pay attention on this slide. This is a very important one, and it has everything whatever we discussed till now. These are the symptoms and signs of labor. These are the stages of the labor, and these are the phases. So all of them are combined in one slide. Cervix not dilated. Now see that this is false labor, or the lady is not in labor till now. Sometimes she may have abdominal pain and she is confused. Probably this is labor pain, and she came to hospital. And it is our job, okay, to make sure whether this is a true labor pain or false labor pain. Already discussed so many times. Remember, true labor pain is associated with cervical effacement and dilatation, whereas false labor pain is not associated with that. Now, cervix dilation less than 4 centimeter. This is okay. This is one of the phase of first stage of the labor, and that phase is the latent phase. You see this? This is first stage of the labor and latent phase. You can clearly see it here. Now, from 4 centimeter to 9 centimeter, still this is the first stage of the labor, and now it is called active phase. Okay, first stage of labor, active phase. Rate of dilation is much more quicker than the latent phase, and in this phase the fetal descent begins. Now after that we move on to the second stage of the labor. See that cervix is fully dilated, which is 10 centimeter. Fetal descent, which has already started in the active phase of the first stage, continue, and there is no urge to push, which is known as early phase or non-expulsive phase of the second stage of labor. And another phase is the late phase or expulsive phase, where the presenting part of the fetus reaches the pelvic floor and that woman has the urge to push. There is active pushing, okay, from the mother. So these are some of the very, very important points which we have talked till now. Let's move on. Now another part of the discussion is how to assess the engagement and descent of the fetus by clinical examination. How I know the fetal head is engaged or presenting part is engaged, and how much the fetus has descended into the pelvic cavity. Now descent is known by abdominal palpation or abdominal examination. Now see there, by abdominal palpation, we can assess the descent in terms of fifth of fetal head palpable above the symphysis pubis. So this is fifth of fetal head palpable above the symphysis pubis. So let us explain this further. A head or the fetal head that is entirely above the symphysis pubis is 5 by 5 palpable. 5 by 5 palpable means it has not gone into the pelvic cavity at all. Okay, it has not entered into the pelvic cavity. Whereas a fetal head that is entirely below the symphysis pubis is 0 by 5 palpable, means it has completely gone down into the pelvic cavity. So this is a very, very important point to know about the fetal descent. Remember, without the fetal descent, fetal cannot be delivered, isn't it? It's quite logical. That's why this is an important part of the examination. Now, all of you, please pay attention on this slide. See here, here is a baby. Okay, this is the presenting part of the baby, that is head. Now, head is mobile above the symphysis pubis. It has not entered into the pelvic brim or pelvic inlet or pelvic cavity. We can completely feel the fetal head with our hand. In other word or in other way, okay, see here, if we can put all of the 5 finger of our examining hand above the symphysis pubis over the fetal head, that means if head is accommodating the full width of 5 fingers above the symphysis pubis, it has not descended at all. Whereas in this condition, see this, you cannot see the complete head, right? A part of the head is already entered into the pelvic brim or pelvic inlet. So it is 2 by 5 above the symphysis pubis. Now, how I know it practically? Only the 2 finger, okay, is there on the fetal head, or head is accommodating only the 2 finger above the symphysis pubis. That's why it is 2 by 5. If only 1 finger is accommodated here, this is 1 by 5. If none, if fetal head is completely gone into the pelvic cavity, it is 0 by 5. If all 5 fingers are accommodated, 5 by 5 means it has not entered at all. So this is very, very important practical knowledge about descent. Now another way of finding descent is by vaginal examination. Now till now we are talking about abdominal palpation, but now vaginal examination. Now how we know that? So let's talk about it. If necessary, a vaginal examination may be used to assess the descent. See here, to assess the descent by relating the level of the fetal presenting part to the ischial spine of the maternal pelvis. Now ischial spine, okay, this is a part of the ischium bone there. You have to go through your anatomy, okay, of the pelvic bone. Pelvic bone has got 3 parts: ilium, ischium, and pubis. Now right now this ischial spine is a part of ischium bone. Okay, so it is related to the level of the fetal presenting part to the ischial spine of the maternal pelvis. Now one important practical point here is, if there is a significant degree of caput or molding of the fetal head, okay, Assessment by abdominal palpation using fifth of the head palpable is more useful than assessment by the vaginal exam. Because of this caput or molding, we may over calculate the amount of fetal descent, but actually the head has not descended that much. Now you should know the meaning of caput or molding. Now anybody can tell me what is caput? Yes, anyone? Maybe you have heard this term before. Caput, what is that? Anyone? Now this may be a new term for you. Okay, so probably yes, anybody? Now listen
Sir,
here.
it's like a caput medusa.
Okay, not really. Now listen here. This caput is actually also known as caput succedaneum.
Filling of the scope of the baby.
So let me explain here. Please listen. Pay attention here. This is also known as caput, okay, succedaneum. Caput succedaneum. Okay. Now what is the meaning? The meaning is there is edema of the fetal scalp. Edema of the fetal scalp. And this fetal scalp, okay, is a part of fetal head, isn't it? Scalp is a skin covering of the head. This is a very thick type of skin. We all know that. There are 5 layers on the scalp. Let's not go into the detail now. Just know the meaning of scalp here. There is edema formation. After the edema formation of the fetal scalp, okay, it may form a rounded mass there, and we can palpate that mass when we are doing per vaginal examination. So it looks like, okay, the fetal head has come way down, but actually you are feeling that mass of the caput there. That is the meaning. And molding, on the other hand, molding means overlapping of the fetal skull. That is molding. Overlapping of the fetal skull. That's another term. Okay. So let's move further. Now, please pay attention here. This is a very informative slide. Assessing the descent of the fetal head by vaginal examination, and zero station is at the level of the ischial spine. It is called zero station. Now see that this is the ischial spine, this pointed part. So let me use the pointer here. It's right here. This SP is the ischial spine. Okay. So if the head reaches exactly at the level of the ischial spine, this is called zero station. Above than that, we call it minus station, and below than that, we call it plus station. So +1, +2, +3, and +4. +4 means the head can be visible outside. Okay, head is crowned. This is called crowning of the head. Important point. And another, see that the head has not even entered the pelvic cavity. In the -5, it has not entered into the pelvic cavity at all. So these are the different points here. Another part of this topic is how to identify the presentation and position of the fetus. Let's talk about it. Presentation and position of the fetus. The most common presenting part is the vertex of the fetal head. The most common presentation is the vertex presentation. We say that we know this already. Another type of presentation, can be breech presentation, shoulder presentation. The different points are there, but the most important one or the most common one is vertex. If the vertex is not the presenting part, it is called as malpresentation, and we should manage accordingly. Now this is a complicated type of labor. Now if the vertex is the presenting part, use the landmark on the fetal skull to determine the position of the fetal head in relation to the maternal pelvis. Now there are different landmarks on the fetal skull. Okay, so let me explain this for you. Now see here first. Okay, these landmarks on the fetal skull are important here to determine the position of the fetal head in relation to the maternal pelvis. Now let's talk about them in the next slide. Now see there. So these are the landmarks of the fetal skull. So please pay attention here. This is anterior fontanelle. Anterior fontanelle. Here is posterior fontanelle. These are the parietal bone. These are the frontal bone. Here is occipital bone, and temporal bone is a bit below, so we cannot see it from this angle or this view. Okay, but temporal bones are also there on the fetal skull. They are inferior to the parietal bone. So frontal bone, parietal bone, okay, occipital bone, and the temporal bone, which are not seen here. So this is the sagittal suture between two parietal bone. This is called coronal suture. Okay. Coronal suture. This transverse type of suture is called coronal suture. You all know that. This is the frontal suture. Okay. Later on, it is fused. All of these sutures fused later on. And what is fontanelle now? So you can clearly tell me by looking here. What is fontanelle? Yes.
The fontanelle is present between the two sutures, sir.
Exactly. Exactly. Absolutely right. Yes. Every student can see here and tell, isn't this is a suture? This is a gap. See there, this is a gap present between the suture. This is a big diamond like area or space present between the suture. There is a sagittal suture, you can clearly see. There is a coronal suture and there is a frontal suture. So this is anterior fontanelle, here is a posterior fontanelle. So what I mean here, by doing vaginal examination, we can feel this fontanelle, we can feel these bones. Then we know what is the position of the fetal skull according to the maternal pelvis. The fetal head normally engages in the maternal pelvis in an occiput transverse position with the fetal occiput transverse in the maternal pelvis. Now that is very easily explained by this picture. See here, this is the maternal pelvis. Okay, this is the bony pelvis. Now here is the fetal skull. You can clearly see this is fetal skull. The bigger gap is anterior fontanelle. The smaller gap is posterior fontanelle. This, okay, fetal skull is present in the transverse position. See this? This is transverse position. Now how I know this is transverse? Look at the arrangement of the fontanelle here. It is exactly transverse in comparison to the maternal pelvis. This is important one. So left occiput transverse. And which is occiput now? Occiput is present towards the posterior fontanelle. This is occiput. This bone is occiput. So wherever the occiput is present, we call it left or right. So in this case, it is present on the left side. Okay. On the other picture, it is present on the right side. The occiput is present on the right side. So it is called right occiput transverse. This is left occiput transverse. So listen once again here. The fetal head normally engages in the maternal pelvis in an occiput transverse position. Now, what is engagement? This is the new term for you. Probably we have explained this in the before classes also. So let me ask this question to my student. What is engagement? Anybody? What is engagement?
So passage of skull through the pelvis and attachment to the boundary.
Okay.
Movement of the presenting part below the pelvic inlet.
Good. Okay, Irfan and Imran, you are answering very good. Now listen here, all of you. If the maximum diameter, okay, maximum diameter of the presenting part has entered into the pelvic brim, we call that engagement. when it has entered into the pelvic cavity, the maximum diameter of the fetal head, which is called engagement. Quite an easy term. Okay. With descent, the fetal head rotates so that the fetal occiput becomes anterior in the maternal pelvis, and we call it occiput anterior position. Now see that with descent, the fetal head start to rotate. Okay, so occiput will come into the anterior position of the maternal pelvic cavity. When it is engaging, it is in the occiput transverse position, but now the occiput will come into the anterior position. Very easy to understand. And failure of this rotation to an occiput anterior position should be managed as occiput posterior position. This is an abnormal position of the fetal head, and it may give rise to some of the complication. So it should rotate and become occiput anterior. Now that thing which we just talked, look at this picture and try to understand. See here now. So this left occiput anterior. Left occiput anterior. Now why it is called left occiput anterior? That's the point you need to understand from this picture. Now let me go through the landmarks once again. This bigger diamond shaped gap is anterior fontanelle. Here is the posterior fontanelle. So this is the occiput. This bone is occiput. Now see this. What is this joint? Yes, what joint is this? This which I am showing with the pointer. Symphysis pubis, excellent, or pubis symphysis, whatever you want to say. This is always present on the anterior side. So this is anterior side of the pelvic cavity. Here is the sacral bone. This is called sacral promontory. This is the posterior part of the pelvic cavity, and these are the pelvic bone itself. Okay, these are the pelvic bone. So pubic symphysis is here, sacral promontory is here, and these are the pelvic bone. Here is a fetal skull. You can clearly see this is posterior fontanelle. Here is anterior fontanelle. So here is the occiput. So very clearly this occiput is facing the anterior side. Okay, and it is on the left. So left occiput anterior. Now see this, right occiput anterior. So this is anterior side, and here is the right side. This is right side. Okay, so right occiput anterior, and this is occiput anterior. No left, no right, because the occiput is exactly present on the anterior side. See this, it is located right below the symphysis pubis. So occiput anterior. Now these are a little bit difficult terms in the beginning, okay, but if you pay attention there, if you know why it is called like that, it is not difficult at all. Let's move on. Now with this knowledge, let's determine the position of the fetal head. An additional feature of a normal presentation is a well-flexed vertex with the occiput lower in the vagina than the sinciput. Now let me go through this again. An additional feature of a normal presentation, see that this is called normal presentation, is well-flexed vertex with the occiput lower in the vagina than the sinciput. Now please pay attention to this picture. Here is the occiput here. This is the birth canal. Okay, this is birth canal. The head is still in the pelvic cavity, but later on it will enter into the vagina. This occiput is in the lower position than the sinciput. Now you may be wondering what's the meaning of sinciput. Sinciput is the area present between the vertex and the forehead. Vertex and the forehead. Now see this is called vertex. Exactly the top of the skull, vertex, and forehead is right here, forehead. So this area is called sinciput. So sinciput should be above the occiput in a well flexed vertex in a normal type of position. If sinciput is lower than the occiput, remember this is not the normal position. It will cause a lot of problem in the delivery of the baby. Now, please pay attention here. This is a very important slide if you want to understand this correctly. So see here, please. This is vertex presentation. Vertex presentation means, see this, the top of the skull of this, okay, everybody know what is vertex, is the presenting part. So vertex presentation. This is a sinciput. The presenting part is a sinciput here. So this area is sinciput, okay, from the vertex till the forehead. This is sinciput. This is called brow presentation. Brow is a forehead presentation. This area, forehead presentation. See there, the fetal head is excessively extended. That's why brow presentation. And this is face presentation. The extreme type of extension can even result in face presentation. So vertex presentation, sinciput presentation, brow presentation, and face presentation. All other are abnormal except vertex. Vertex is the normal one. Now let's move further. Now here, the relation of an arbitrary chosen point of the fetal presenting part to the right or left side of the maternal birth canal, okay, is called position. Now the chosen point in this case are, for the vertex presentation, the chosen point is occiput. For the face presentation, the chosen points are mentum, and for the breech presentation, the chosen point is sacrum. Everybody know about occiput. What is mentum? What do you mean by mentum? Anyone? Mentum means chin.
Sir, it is the base of the labium, sir. Like,
It's a chin, okay? Chin. Chin is called mentum. Just remember that much. Chin is called mentum. So that is a landmark or the chosen point. And for the breech presentation, it is a sacrum. So all of these are bony point. So this is an arbitrarily chosen point of the fetal presenting part, so that accordingly we can explain the position. So each presentation has two positions, right or left, and each position has three varieties: anterior, transverse, and the posterior. So to make you understand in a good way or easy way, look at here, then it will be very, very clear for every one of you. So see there. Okay, so here on this side is the right side, this is the left side. This is neither right nor the left, this is the midline. So if occiput is facing anteriorly, this is occiput anterior, occiput posterior. Quite easy. This is left occiput anterior. Occiput is present towards the left side and anteriorly, left occiput anterior. This is left occiput transverse, left occiput posterior. What do you mean by that? Occiput is present posteriorly and on the left side, exactly in the midline, occiput posterior. Now this is right occiput posterior, right occiput transverse, and right occiput anterior. So this is known as position of the fetal head in relation to the maternal pelvis. Now, how much we have understood from this type of discussion? Let's go through this and identify them correctly. This is the longitudinal lie and vertex presentation. See this, the head, okay, head is presented, but why this is called left occiput anterior? This is the answer you need to give by looking at this picture. Left occiput anterior. Now, where is the occiput here? Occiput is always present on the back side. Okay, here is the occiput. Here is the occiput. Okay, this is the left side, so it is facing the left. Okay, so it is very easily, known by this picture. Here is the occiput bone. This is the left side. Okay, so left occiput anterior, and this is the anterior. Of course, there is the pubic symphysis here. Pubic symphysis is always present on the anterior side. This is sacrum presenting on the posterior. So on the other hand, this is left occiput anterior. Why? Look at the occiput bone here. This is the posterior side, and this is the left. So left occiput posterior, and the baby looks like this now. Okay, baby looks like this, left occiput posterior. This is abnormal type of presentation. Now, similarly, okay, all of you please pay attention here. This is right occiput posterior. So why? See here, where is the occiput? It is right here. This is the right side. Okay, and this is posterior side. Now right occiput transverse. Look at here, it is exactly transverse. Exactly transverse. So occiput is facing on the transverse direction. So right occiput transverse. Now, what is this? Right occiput anterior. Why it is called right occiput anterior? This is, okay, see this. This is the occiput bone here. So let me use the pointer once again so that student can understand it. Here is the occiput bone. This is right side. Okay, here is the left side. Okay, so it is facing this one, right side. So it is right occiput, but whether it is anterior or posterior, how I know it? This is symphysis pubis, so it is facing on the anterior side. That's why it is called right occiput anterior. So sometimes in your Viva exam or in your OSCE exam, the teacher love to ask, can you tell me the position of the fetal skull in relation to the maternal pelvis or birth canal? And you have to exactly find out like this, okay, and give the answer correctly. After we have discussed about labor and the important stages of the labor, what are the phases of the labor, what are the different presenting parts, what are the different positions, let's know about what is the mechanism of the labor, means what is the real process involved there, how the presenting part descends downwards, what are the different mechanism involved. Very, very important topic. So these are the classical steps in the normal mechanism of the labor. So let's list them first, and then we'll elaborate each of them. They are descent of the presenting part, engagement of the presenting part, flexion and internal rotation, crowning of the presenting part, extension, restitution, and external rotation. There are so many terms there. Okay, some of them are very new to you, so we need to explain all of them. Okay, and this class is all about that. So let's say vertex presentation is the most common type of presentation, or cephalic presentation is the most common one. So let's take the example of head and then discuss all of this. So descent of the fetal head, engagement, flexion and internal rotation, crowning, extension, restitution, and external rotation. Usually, labor progresses in this fashion. If the fetus is of average size, with a normally positioned head, in a normal labor pattern, in a woman whose pelvis is of average size and a gynecoid in shape. So if everything is normal, then only this can happen. That is the meaning. Though there are so many important terms which are highlighted, but the point is that if everything is normal, these classical steps are followed. Okay, if the pelvis is android, means male type of pelvis, some of the ladies are having that, then probably there is some amount of obstruction occurring, and this classical rotation cannot happen. there is an overlap of these mechanisms. For example, flexion is continuous in so many different steps. Internal rotation is also quite common in different steps. So there is a good overlap of this mechanism. Now, before we go onto the mechanism, every student should know a little bit about the pelvic anatomy. What do we mean by pelvic inlet, and what is pelvic outlet, and what is pelvic cavity? So please pay attention here. These are the borders of the pelvic inlet. Now see there. This is called pelvic inlet. Okay, this uh, structure. Now, what is the anterior border? What is the anterior border of the pelvis? Pubic symphysis. You can clearly see here. Please mute yourself. Pubic symphysis. This is the posterior border, which is formed by sacral promontory, and this is the lateral border, which is formed by iliopectineal line. Iliopectineal line it is called. This is iliopectineal line. Here is the sacral promontory. This is a part of the sacrum bone. It's a type of vertebra, and this is pubic symphysis joint. So this is called pelvic inlet, also known as pelvic brim. Okay, let's move on. Now these are the borders of the pelvic outlet. Pelvic outlet. After the baby crosses the pelvic outlet, okay, then the baby will enter into the vagina, and then labor or delivery of the baby occurs. So what are the borders of the pelvic outlet? Posteriorly, tip of the coccygeal vertebra or coccyx, laterally ischial tuberosity, and anteriorly pubic arch. So this is the anterior again. So here is the pubic arch. It's a part of the pubic bone. This is called ischial tuberosity. You can clearly see here these pointed bones, which forms the important part of our buttock. And then posteriorly is the tip of the coccygeal vertebra. So this is called pelvic outlet. Now everyone know pelvic inlet and pelvic outlet. Now some more information here. What is the transverse diameter and AP diameter of pelvic inlet, mid pelvis or pelvic cavity, as well as pelvic outlet? Let's talk about them. The transverse diameter of pelvic inlet is 13 centimeter in comparison to the anteroposterior diameter, that is 11. So very clearly the transverse diameter of pelvic inlet is more than AP diameter. You can clearly see it here by 2 centimeter. In the mid pelvis, both transverse diameter and AP diameter is the same one, and in pelvic outlet the transverse diameter is 11, whereas AP diameter is 13. So AP diameter is more in the pelvic outlet than the transverse one. So let me go back to that same picture again. Okay, so you should know what is AP and what is transverse here. See this. This is transverse. This is transverse, and this is AP or anteroposterior. This is anterior side of the pelvis. This is posterior side, and these are the lateral. Okay, so this is the transverse, definitely very easy to understand, and this is the AP. So what I mean here, the transverse diameter is more in the pelvic inlet than the AP diameter by 2 centimeters, whereas in pelvic outlet the AP diameter is more than the transverse diameter. It has got a very important implication. So what is that implication? Let me explain that now. Since the transverse diameter is greater than the anteroposterior diameter in the pelvic inlet, the widest diameter of the fetal head descends in a transverse position. So when it enters into the pelvic cavity, okay, it has to enter or descend in the transverse position. That's why we call it occiput transverse position when it enters inside, or when it descends inside the pelvic cavity for the first time. However, when it gets closer to the pelvic outlet, the nature of the pelvic floor muscles encourage the fetal head to rotate from a transverse position to the antero-posterior position, because near the pelvic outlet the antero-posterior diameter is greater than the transverse diameter. That's why the fetal head, okay, will attain the antero-posterior position at the pelvic outlet, and it happens because of rotation. Remember, when it is descending downwards for the first time, it is in transverse position. Later on, it turns into AP position, and this is done by rotation. Let's move on. Okay. Now, another important point here, the fetal head diameter varies depending upon the degree of neck flexion. The normal, position which is attained by the fetal head is flexion. I already talked about this in the topic of labor. How much neck flexion is there, okay? This determines what is the diameter of the fetal head, okay? Like occipitobregmatic is 9.5 centimeter diameter. Now in this, okay, the neck is flexed and the presentation is vertex. This is vertex presentation with flexed neck, and we call that suboccipitobregmatic diameter, which is 9.5 centimeter. It is the smallest one. Occipitofrontal in vertex presentation and neutral flexion, okay, not much flexed here, is 11 centimeter. Submentobregmatic, that is face presentation, it is 9.5 centimeter again, but face presentation is never considered a normal one. And verticomental, that is brow presentation. Now brow is forehead, this is 13.5. The maximum diameter is attained by this type of presentation, verticomental. Okay, so this is a slight knowledge. It's a bit difficult for you at this stage to understand this, but trust me, when we move further, okay, into the different parts of this lecture, this knowledge will be very easy. Now let's start the further discussion. What do you mean by fetal descent now? The fetus descends into the pelvis, okay? The fetus descends into the pelvis in this mechanism. Please mute yourself. In the primigravida, this is likely to occur from 38-week gestation onward, whereas in a multigravida, this may not occur until labor is established. So primigravida means for the first time they're pregnant. So it may start right from the time the pregnancy become term, that is 38 week onwards. Whereas in a multigravida, it may not happen until labor is established. Now what do you mean by established labor? When there is true labor pain starts. That's the point. Now, descent is encouraged by this mechanism. Let's explain this now. Increase abdominal muscle tone, Braxton Hicks contraction in late stages of pregnancy. What do you mean by Braxton Hicks contraction? Yes, what do you mean by that? It's uterine contraction, absolutely. This is uterine contraction. Exactly, it's a rhythmic contraction of the uterus, okay? Just the term is different, Braxton Hicks contraction, which is regular towards the late stage of the pregnancy. Fundal dominance of the uterine contraction during labor. Fundus has a good amount of muscle. So if fundus contracts vigorously, then descent will be definitely encouraged. And increased frequency and strength of the contraction during labor. This is called true labor pain. And true labor pain are because of rhythmic and regular uterine contraction. So these are the different forces which will push the baby to descend downward. That's what we are talking about. One thing which is not mentioned here, but you can always add from your side, is the anterior abdominal wall muscle contraction by the mother is also helping to push down the baby. As the head descends, see that very important point, it moves towards the pelvic brim in either the left or right occipito-transverse position. This means the occiput can be facing the left side or right side of the mother's pelvis. So many times I already discussed this, because that, okay, is the highest diameter or the biggest diameter in pelvic inlet. That's why the head is attaining occipito-transverse position. This is the descent. Now see there. So this is another slide which is telling us the same thing, but in a very easy way. So please pay attention here. In descent, the baby descends through the pelvic inlet towards the pelvic floor. Yes? Yes, please.
Sir, allow me for recording. I was disconnected.
Okay. I will allow you. Okay. Wait. Fine. So let's continue. What I'm talking about is what happens in the descent. Here the baby descends through the pelvic inlet towards the pelvic floor, and when the presenting part touches the pelvic floor, there will be internal rotation, there will be flexion of the neck, and that will further change the position. Remember, when it enters inside, it is occipito-transverse position. Later on, it will turn into occipito-anterior position. This is because of the rotation and the flexion. So descent occurs due to uterine contraction, amniotic fluid pressure, and abdominal muscle contraction, to summarize. Okay, and this exactly the descent happens like this. See there, this is the baby, okay. This is the pelvic cavity, and the baby is going downwards. Now the second important mechanism, what is engagement? Engagement, okay, occurs when the largest diameter of the fetal head descends into the maternal pelvis. So this is engagement. It is engaged into the pelvic cavity. It has entered into the pelvic cavity. This is called engagement. The term engagement is referring to the widest part of the fetal head successfully negotiating its way down deep into the maternal pelvis. And engagement, remember the topic of labor which we have just discussed. Engagement is identified by abdominal palpation, where the fetal head is 3/5 palpable or less. If you have, okay, less than 3 finger, that means 2 finger or just 1 finger is there, which is accommodated by the fetal head, that means the engagement has already occurred. But if I still can accommodate 5 of the finger when I am palpating the abdomen, that means engagement has not still happened. Till 4 finger it has not happened. 3 finger afterwards, okay, it has happened, means it has entered inside. That's why I cannot put my finger over the fetal head when I palpate the abdomen of the mother. So this is called engagement. Now see there, okay, please pay attention. This will make you understand. Engagement occurs when the largest diameter of the fetal head fits into the largest diameter of the maternal pelvis. So many times we talked about, now it is very easy or clear for you. As the fetal head engages, the head moves towards the pelvic brim in either the left or right occipito-transverse position. This is always in the beginning. Later on, it will get rotated there, okay, and it will attain occipito-anterior position. Now, this is the picture which is clearly showing you the same thing. Look here, this is anterior fontanelle, towards here the posterior fontanelle, okay. So this is exactly transverse position, occipito-transverse position. Now, another very important mechanism, okay, you have to understand is the flexion. Now, flexion means flexion of the neck. While descending through the pelvis, the fetal head flexes so that the fetal chin is touching the fetal chest. Now look at this picture here. The fetal chin is touching the fetal chest. So this much flexion is normal. This has to occur in the normal labor. This functionally creates a smaller structure to pass through the maternal pelvis. Now, one question should come in your mind, why this type of flexion is occurring? Why not? The head is delivered, or the mechanism is continuous through the extension route. Because the smaller structure of the fetal skull has to pass through the maternal pelvis, and this is held by flexion of the neck. Now what happens here, when flexion occurs, the occiput, okay, fontanelle or posterior fontanelle, rather it is known as posterior fontanelle than occipital fontanelle, it slides into the center of the birth canal and the anterior fontanelle becomes more remote and difficult to feel, isn't it? It is more remote and difficult to feel. Now look at the second picture, you can understand it very easily here. When the obstetrician is doing per vaginal examination, they can easily feel this occiput part or the posterior fontanelle part rather than the anterior fontanelle because of the flexion. Because of the flexion, the anterior fontanelle is going away, okay, going away, and it is difficult for us to feel now. It is going away from the birth canal, but posterior fontanelle is coming at the center of the birth canal and it is easier for us to palpate. This is all caused by flexion of the head and neck. In this mechanism, the fetal position is still occipito-transverse, which you can clearly see on the picture. This is called occipito-transverse, see there, okay, exactly transverse position. Let's move on. So to summarize what happens in the flexion, as the fetal head comes into contact with the pelvic floor, the cervical flexion occurs. And the complete type of cervical flexion occurs when the chin touches the chest of the baby. This allows the presenting part of the fetus to be suboccipito-bregmatic, which is just 9.5 centimeter in diameter. Just now what I told you, what is the principle of this flexion? The principle of the flexion is the presenting part want to become as smaller as it can, and this is the smallest one, the suboccipito-bregmatic, just 9.5 centimeter. This is the purpose of flexion. In this position, the fetal skull has a smaller diameter which assists passage through the pelvis easily. Now, please pay attention on this slide. See that. So what is happening here? Let's follow one after other. Just compare this. This was the the position when it is entering into the pelvic cavity, and slowly when it reaches the pelvic floor, see that it gradually start to flex. It has become like this now, and ultimately it is flexing. Now look at here, the anterior fontanelle in comparison to here, the anterior fontanelle can be easily palpated because of per vaginal examination in this, but see here, okay, it is difficult to palpate because of the flexion of the head and neck. And this is considered the normal mechanism. Now, let's move further. What is internal rotation then? Now, regarding the internal rotation, with further descent, the occiput rotates anteriorly and the fetal head assumes an oblique orientation now. Means it is started to rotate now. It has started to rotate. Now, what is the direction of rotation? Remember, the occiput should come anteriorly. Occiput should come anteriorly. Now see this. This is anterior fontanelle. Okay, here is the occiput, and this is symphysis pubis. So this occiput is going anteriorly because of the rotation. This is called internal rotation. This is a part of the mechanism of labor. So to summarize with, the pelvic floor has a gutter shape with a forward and downward slope, and this allows the head to rotate from a left or a right occiput transverse position to an occipito anterior position. This is known as internal rotation. Let's move on. Okay, now we have reached to the another important step, which is called crowning. Look at this picture first. This is called crowning. See here, the presenting part is visible, okay, from outside, means from the birth canal it is visually visible, and okay, and when the contraction is over, it doesn't go back. This is very important point in the crowning. Now with this information, let's go further. When the widest diameter of the fetal head successfully negotiates through the narrowest part of the maternal bony pelvis, the fetal head is considered to be crowning. So let me make easier for you. When the widest diameter of the fetal head successfully coming down through the narrowest part of the maternal bony pelvis, that is pelvic outlet, when the widest part of the fetal head descends from the narrowest part of the pelvic outlet, it is known as crowning. And in between the contraction, it doesn't go back because it has already come out, it has already crossed that narrowest part of the bony pelvis. In this position, the head stretches the vulval outlet without recession of the head even after the contraction is over, means it doesn't go back in between the contraction. And when the crowning occurs, the delivery is very imminent. Okay, it will occur very soon. So crowning has got a very important signal in the delivery room. Now another important step is the extension. Now see here, this is extension. Now what happened? The head is delivered by extension. So this is the extension. The head is extending here. Okay, the head has come out from the birth canal or from the vagina. So this is extension. I'm sure every student understand what is extension and flexion. See there, when the chin is touching the chest, this is called flexion. Okay, when it is moving away from the chest, or in other word, when occiput is going near to the back, this is called extension. See this exactly. Okay, this is extension position. So let's summarize this one. When the occiput slips beneath the suprapubic arch as the head extends and the nape of the neck is pivoting against the arch, this is called extension. So they are explaining like this, but let me make it very easier for you. Look at this picture. It is so easy to understand. This is extension of the head. Every student can know this very easily. Okay, in the beginning, the chin was touching the chest in the flexion position, but now the head is gradually extended. That means chin is moving away from the chest, or in other words, the occiput is going nearer to the back. This is extension. Now, what is restitution? What do we mean by that? Look at this here. This picture is telling us about restitution. Because the shoulders at the point of the head being delivered are only just reaching the pelvic floor, they are often still negotiating the pelvic outlet, and the fetus may naturally align its head with the shoulder. The rotation of the shoulder is going on inside. The internal rotation of the shoulder is going on because shoulders are not yet delivered here. Okay, shoulders are still inside. Means the rotation of the shoulder is going on, and for the alignment of that rotation, the fetal head is slightly rotated itself, and this is known as restitution. This is known as restitution. It is considered, okay, one part of external rotation. Internal rotation is going on inside, which we cannot see from outside. But remember, when it is rotating in a different direction, the head, which is seen outside now, will rotate in a different direction. This is called restitution. Visually, you may see the head externally rotate to face the right or left medial thigh of the mother. So here is the thigh of the mother. Okay, this is the medial part of the thigh. So the head is, okay, facing the right or left medial thigh of the mother. So see there, if this is a, okay, if this is a left side here, this is a left side, the occiput is facing the left in this condition. So external rotation and restitution, the head externally rotate to face the right or left medial thigh of the mother. It's very easy sentence. You can just remember this. But that was the mechanism which was earlier described. Why it happens? Because internally the shoulders are also rotating. What is external rotation then? It is just the extension of restitution. It is the movement of rotation of the head visible externally due to internal rotation of the shoulders. Now see that it has completed. This is the external rotation. In other words, it is the extension of restitution itself. Now, what is the next step then? Okay, after that, the head is delivered. The head is delivered, and head is delivered by the extension. And after that, okay, after that, we should slightly help for the delivery of the shoulders. Now see that there is a right shoulder and the left shoulder, and when this shoulder is coming out, the person who is helping the delivery process, like a midwife or the nurse, they should simply, okay, push the head downwards and try to take that shoulder out. And similarly, okay, a little bit pulling up the head upward and taking the another shoulder out. This is how the delivery is done. And after head and shoulders comes out, rest of the body will come out very easily.